Good afternoon, everyone. It is with great pride and deep gratitude that we welcome you all to this launch of the research report of the Regional Health Governance Study. This report marks an important moment in efforts to enhance health systems, promote resilience, and deepen collaboration across borders. This report brings together the wisdom and experiences of institutions and experts within this field and examines how regional organizations respond to global health crises. The findings underscore that effective regional health governance is more than a technical arrangement. It is a community of practice and a bold vision for the future of global health equity. So as we strive to decolonize health governance and empower regional voices, we must ensure that our systems are rooted in justice, inclusiveness, and sustainability. And without more, I am going to be introducing my co-moderator, Jake Efodu, for the land acknowledgement. Thank you.
Thank you very much, Professor Udoka, and welcome everyone. As Professor Udoka mentioned, this is not just a report. It's not just another document. It's pretty much a movement. And I think it reflects the shared urgency, the vision of scholars, legal minds, public health professionals who have worked in this space. And so to begin, I think it's important to acknowledge that we gather on a land known as the Dish with One Spoon territory. So this is the place where I am at the moment. You might be in a different place. And I think it's important to recognize if it applies to where you are physically speaking, even though we connect through a digital platform. So where I am right now, and I think where a couple of us in Toronto, is pretty much on a territory that has been shaped by a powerful agreement between the Anishinaabe, the Mississaugas, and the Haudenosaunee peoples. So this treaty, it wasn't just about boundaries. It was a commitment to share the land and care for it all together. It's as if, we're all eating with one dish, with one spoon, so that no one is taking more than they need, and everyone is ensuring that the dish is never emptied. Toronto, where I am, also rests on the land covered by Treaty 13, signed in 1805 between the Crown and the Mississaugas of the Credit, and by the William Treaties of 1923, involving several Mississaugas and Chippewa bands. Now, these treaties are not just historical footnotes, and this is not just a recital. I think they are living agreements that continue to inform our responsibilities to the land, especially as we talk about regional health equity and solutions for dealing with issues like the global pandemic up till today. So thank you very much. And I would like to say that this event is co-hosted by the African Society of International Law, the Special Interest Group on International Humanitarian Law and Human Rights, which Professor Udoka is a foundational part of, as well as the International Law and Global Justice Initiative at the Lincoln Alexander School of Law, which I'll speak quite briefly about, but I'll let Professor Udoka talk about the African Society of International Law.
Thank you very much, Jake. Thank you very much. So it is my honor to introduce the African Society of International Law at this report launch. And AFSIL is proud to be one of the co-hosts, particularly the International Humanitarian Law and Human Rights Interest Group. We're proud to be one of the co-hosts of this very important launch. Now, AFSIL, the African Society of International Law, as a leading academic and professional platform, it stands as a vital forum for advancing discourse, scholarship, and practice in international law across the African continent and really beyond the African continent. So AFSIL was founded with the vision of promoting the development and dissemination of international law from an African perspective. And AFSIL serves as a unique space for reflection, legal innovation, and institutional engagement. So AFSIL brings together jurists, scholars, legal scholars, practitioners, students, and a wide range of people with the common goal of contributing to the deeper understanding and appreciation of international law in Africa, and particularly as seen by Africans. So to pursue the mission of AFSIL more effectively, what AFSIL has done is to establish a number of interest groups. And these interest groups serve as thematic hubs for legal expertise and collaboration, and really pretty much to amplify the work and the voice of the African Society of International Law. And one of these interest groups is the International Humanitarian Law and Human Rights Interest Group, which I proudly serve as the co-chair. And along with me as co-chairs are also Dr. Uche Ngwaba, who's one of our panelists today and will be speaking today, and also Ms. Darling Seda. And so without further ado, I want to hand over to Jake to introduce the other co-host of this report launch, which is the International Law and the ILIG. And so Jake, please over to you.
Yep. I would also just briefly talk about the International and Global Justice Initiative, which is an initiative under the Lincoln Alexander School of Law. And I need not introduce the Lincoln Alexander School of Law, who's putting together all of this. Topmost frontier law school in all of Canada, the one law school that rests on 4 foundational pillars: equity, diversity, and inclusion, which has become so critical today; access to justice, including health justice; innovation and entrepreneurship; and our 4th pillar is academic excellence. So the ILGJ stands for International Law and Global Justice Initiative. We are committed to bridging theory and practice through what we call a justice-oriented scholarship and public engagement. So our faculty members who work on various aspects of law, from human rights to climate justice, we perceive a deep unity between research, teaching, and experiential opportunities. So at the ILGJ, we always employ an expansive and an imaginative approach to international law and global justice, so that we can address issues of whether international law or transnational law, comparative law, using a Canadian lens to relate to these global issues. Of course, you can find out much more about us on our website, and as well as on the Lincoln Alexander School of Law website as well. All right, we will be happy to get to know who is joining us. So please feel free to use the chat box. You can write your name, your designation, where you're joining this launch from. And then maybe Udoka and I can go into introducing, just speaking a bit about some of the distinguished panelists that we have here who will be speaking to us on today's launch. So Udoka, over to you as well.
Thank you very much for that, Jake. Thank you very much. And so starting off, I will be introducing some of our distinguished panelists. And I'm going to be starting with Dr. Michelle Amri, who's an assistant professor of global health ethics and the Mary Morris Young Professor in Applied Ethics at the School of Population and Public Health at the University of British Columbia. And Dr. Amri's research is situated in the disciplines of public health and global health and contributes to the field of politics of health. Dr. Amri is working to understand how equity can be better incorporated in public policy making, both in terms of how relevant actors consider equity in developing policy. For example, how is equity understood and operationalized, and also how equity can be improved in policy making processes. So looking at multi-sectoral approaches, including those at the city level, decolonizing policy making. Dr. Amri has consulted for the World Health Organization for over a decade, and she serves on the board of directors for the Canadian Association for Global Health, which is co-chaired by the Canadian Conference on Global Health. She co-chaired the Canadian Conference on Global Health in 2023 and 2024. And very importantly, was named to the list of Canadian women in global health. And Dr. Amri, you are welcome to this event. Uche, Jake?
Yes. Thank you very much, Professor Amri. In fact, I was going through the report this morning and I saw a question that you asked, Professor Amri. I think you said, to truly decolonize global health, we must ask who holds the power to define progress, and are they willing to let others lead? So I'm really excited about your viewpoints, and I recognize the contribution you made even in last year's convening. It is my joy to introduce one of our panelists. I would say doctor, even though I don't know if they would accept that. Sarah Fixon Owo, MSN RN. Sarah is a nurse leader and a clinical researcher with deep expertise across emergency medicine, labor and delivery, PACU, medical surgery, telemetry, and community health. Sarah holds a master's in science in nursing from UMass Chan Medical School and a Bachelor of Science in biology from Mount Holyoke College. Her research, very complex, some of which I don't understand, but I'll let you know, includes bacterial studies on Bacillus subtilis. That sounds that sounds serious, like COVID. But immense contributions to global health and pharmaceutical projects. As a speaker, an advocate, researcher on health equity, Sarah bridges clinical practice and scientific inquiry to inform policy, to strengthen health systems, and to advance inclusive data-driven care on a global scale. Sarah, welcome, and thanks for being a part of this report launch, as well as your contributions, including last year in our convening at the Lincoln Alexander School of Law. You're very much welcome.
Next, I am very proud to introduce one of the panelists and who a visionary behind this report and who is one of my co-chairs of the Humanitarian Law and Human Rights Interest Group at the African Society of International Law, Dr. Uche Ngwaba. Dr. Uche Ngwaba commenced his academic career as a research fellow at the Nigerian Institute of Advanced Legal Studies in 2010. Uche subsequently proceeded to Sydney in Australia to undertake his doctoral studies. Now, his doctoral research utilized a comparative method to explore how human rights frameworks can strengthen Nigeria's health system to achieve universal health coverage before taking up his current appointment now as an assistant professor at the Lincoln Alexander School of Law at the Toronto Metropolitan University in Canada. Dr. Ngwaba taught as a sessional lecturer in 3 Australian universities for about 5 years, namely the Macquarie University in Sydney, the Deakin University in Melbourne, and University of Western Sydney. Dr. Ngwaba's scholarship engages multidisciplinary, comparative, and socio-legal methods in exploring complex questions affecting health governance frameworks in the global north and global south, something that he brings to bear in his work on this report. Uche's work also engages extensively with health regulatory systems, and he engages critical human rights perspectives and post-colonial theory to examine how health governance and regulatory systems impact health outcomes in the global north and the global south as well. Dr. Ngwaba currently leads a program of research that is focused on advancing a regional health governance approach in the inter-American system. Dr. Ngwaba, you are welcome to this event.
Thank you very much.
Yeah, I feel like this is the part where we'll put the applause because Uche is, I think in the report, again, just to prove to you that I've read this report, such a rich report, and you all get to have a link to it. You talked about Uche's work, not just this report, emphasizes that there are actually structures, institutions, and mechanisms that can be deployed to mobilize action for equitable pandemic management. And his focus is on the inter-American system. I think, Uche, you are the mechanism itself. You are the President General around this conversation. And thanks for agreeing to be a panelist. It is my joy to also introduce another interdisciplinary scholar who's also one of our distinguished speakers, Professor Omowamiwa Kolawole. He's currently a postdoctoral fellow at the Dalai Lama School of Public Health at the University of Toronto under the prestigious Public Health Black Postdoctoral Fellowship Program, where his research engages with the decolonization of global health governance for more equitable outcomes for developing countries. He also holds a master in law, so it's not just health. He's the interdisciplinary scholar that convenes between health and law and social justice and public health and decolonization, with a PhD in public law as well as a master's in public health from the University of Cape Town. He is a multi-interdisciplinary scholar and advocate interested in questions at the intersection of human rights law, public health, and global health governance, with a specific focus on the African continent. popularly called Dr. Wami. Welcome to our launch and looking forward to your engagement as well.
Thank you very much, Jake.
Thank you very much. You're welcome, Dr. Wami. And I want to introduce one of the panelists, but also one of my co-moderators, the very eloquent, very effervescent Jake Okechukwu Efodru, who's an assistant professor at the Lincoln Alexander School of Law at the Toronto Metropolitan University here in Canada. Jake is also a designated Queen Elizabeth Scholar and a World Economic Forum global expert on human rights. Jake has served as the Chief Counsel for the Africa-Canada AI and Data Innovation Consortium, where he mobilized several machine learning and big data techniques to build strategies for increasing societal preparedness for future global pandemics and other public health concerns. Jake has served as the human rights compliance personnel and responsible AI advisor for this consortium. He has informed the regulatory framework and policy formulation on AI at various institutional levels, including the United Nations, the African Union, and for domestic institutions in several countries, which include Canada, United States, Brazil, and Nigeria. Jake, you are welcome to this event.
Thank you. As you have used eloquent and effervescent, which one will I now use to introduce you? But yeah, last but not the least, I would love to introduce the electric, evocative, eloquent, elegant, enthusiastic, equity justifying co-moderator of mine, Professor Udoka, who is a phenomenal scholar working in the field of human rights, global justice, and social justice as well. Professor Udoka Ndidiamaka Owie is a professor at Yorkville University. She obtained both a PhD in international law and LLM with distinction in international law as well from the London School of Economics and Political Science in the UK. She's also an adjunct professor here at the Lincoln Alexander School of Law, teaching our students about law and justice. She has held the Distinguished Harry Authors Fellowship at Osgoode Hall Law School of York University here in Canada, where she also did her postdoctoral fellowship on a Shirk Partnership Development Grant at the Nathanson Center for Transnational Human Rights, Crime and Security Studies at the Osgoode Hall Law School as well. She's also currently co-chair and the Human Rights and Humanitarian Law Interest Group of the African Society of International Law, and her scholarly works have also included regional health governance within the African Union and beyond. So Professor Udoka, thank you very much for thanking me, and thanks for being a part of this panel. This feels like a CNN interview with everyone's face all well prepared and ready for this launch. I think it's time to move to hearing directly from our panelists as we, hear their opening statements. What do you think, Professor Udoka?
Yes, definitely. And without further ado, I want to introduce Dr. Uche, or I want to invite Dr. Uche Ngwaba to take the lead on that. Uche, over to you. Thank you.
Thank you very much, Udoka and Jake, for such a wonderful opening. Let me begin my remarks by expressing my gratitude for the interest participants have shown in joining this webinar. I believe there is shared recognition in the room that the project of deepening equity in health action during periods of global, regional, and national health crises and emergencies is one that cannot be compromised. The Regional Health Governance Study, a program of research which I lead, and which comprises a multidisciplinary team of researchers spread across at least 7 universities across North America and the Caribbean, is dedicated to this equity deepening project. This research program, which was seeded by a Social Science and Humanities Research Council Explore grant, commenced in March 2022, while COVID-19 was in full sway. By this point, the pandemic had confounded many national health systems across the world and revealed fault lines in the global health governance architecture under the WHO. Powerful states of the global north responded selfishly by prioritizing their national interests at the expense of international solidarity for global health action. Weak states of the global south reaped in large measure the consequences of lack of investments in health systems capacity, research, and development. All these despite the established normativity of the right to health under international law, as well as the international health regulations, which obligated states to cooperate to address the pandemic as a collective. Right about then, WHO and some state actors began looking ahead, turning their attention to how to avoid a recurrence of the costly mistakes of the COVID-19 pandemic. The 2024 revisions to the International Health Regulations 2005 and the very recently concluded negotiations to the Pandemic Treaty was the outcome of that effort. For us at the Regional Health Governance Study, we chose to take a different path. We conceived that the occurrences during the COVID-19 pandemic revealed the need for an intermediate level of health governance at the regional level. Our position was supported by three key motivations, which continue to guide the development of our research program, namely that a regional health governance approach holds greater promise than the existing global health governance approach of the WHO for mobilizing states accustomed to collaborating in solidarity, both on a government-to-government and people-to-people basis, to collectively and equitably address shared health threats. Secondly, that a regional health governance approach can complement WHO's role in global health by alleviating some of the shortcomings associated with the current global health governance framework around equitable pandemic management. And finally, through regionalizing global health governance, a significant stride can be taken towards decolonizing global health by praxis that decentralizes decision-making processes regarding global health priorities. I will end my opening remarks by noting that the Regional Health Governance Study is a decolonial project. We are committed to decolonizing global health by praxis that decentralizes sites of global health power to the periphery. Thank you.
Thank you very much for that, Dr. Ungwaba. And next, Dr. Wamiwa, we're going to invite you to speak. Thank you.
Thank you very much, Professor Udoka and Jake. Thank you very much to Professor Ungwaba for inviting me to be a part of this project at the beginning, and for inviting me to the plenary sessions that were held last year. It was truly insightful. And I think you've touched on one of the true values of this project, consideration of regional governance mechanisms, both as an alternative to global health governance, but also importantly as an add-on. And I think it is important that we do the work of thinking of these two paradigms and not thinking that one option is more preferable to the other, and looking at it on the case-by-case basis, because in some instances, it may be that what we need is a complete overhaul at the regional level based on the needs of the region. And in some other instances, it may be that what is required is a bit more expansion and elucidation at the regional level. But I think that this work holds a lot of value for the work of decolonization, like you have rightly said. And I look forward to unpacking the project and the report that has been so well done, and to the future work that we'll be doing on the regional project and particularly in the context of Africa, which is my own particular site of interrogation. So thank you very much to everyone, and I look forward to very robust discussions.
Thank you very much, Dr. Wami. And Dr. Amri, Dr. Michelle Amri, please.
Thank you so much to the both of you for this kind introduction. I'm honored to be a part of this session here today, joining from the ancestral and unceded territory of the Musqueam people, and I'm delighted to be a part of this regional health governance study. The premise of the study is that really a regional approach can afford greater benefits than the status quo. And I want to clarify that when we discuss a regional approach, we're not talking about decentralization in terms of how we use regionalization within Canada. The benefits of taking such a regional approach are clear, particularly following the COVID-19 pandemic, for instance, through data sharing and supply chain coordination. But I would actually argue that one of the greatest benefits that it affords is increased decision-making power to policymakers within countries. By shifting global health decisions to be more regionally determined, this changes the dynamics in the field from one where institutions of the global north are dictating the work to be done in countries and at the expense of countries, to perhaps moving towards addressing country-determined priorities through leadership and funding at the regional level. Such an approach aligns with the decolonizing global health movement, as was mentioned, and really taking an anti-colonial approach. But at the same time, we can't neglect that the infrastructure for a regional approach exists, such as through the WHO's 6 regional offices. But understanding that these regional offices have limitations can allow us to really think through how these existing structures can be optimized. What would it take to enhance regional health governance? What or who would be the responsible coordinating body, if any? Would the focal points be strictly within ministries of health, given that this is typically the global health entry point? Or would enhanced regional health governance also include those in other ministries, given that areas like pooled purchasing are not completed strictly by those working in health? What would the main tasks of those seeking to focus in on regional health governance be? And these questions are just a small snapshot of pertinent questions that I hope that the study and the work to be undertaken will uncover. So as you can see, it's an ambitious goal driven by great need, and I'm sure that you'll feel enthusiasm for this work throughout the webinar. So I thank you for joining us today.
Thank you very much, Dr. Amri. And I'm going to be introducing Sarah Fixon next. Sarah, the floor is yours.
Hi, everyone. Thank you all for being here, and special thanks to the organizers for inviting me back. I'm grateful to be a part of this important conversation. It is truly an honor. So my projects focus on the role of human rights-based approach in pandemic management. So come with me while I take you on a journey. So imagine it's 2029. A new virus has emerged. Borders closed, hospitals overflow, loved ones lost, and the global economy collapses again. The world turns to us for leadership. What will we say? That we knew this was coming and we did nothing? So over the last century, we faced at least 6 major pandemics, including the swine flu and COVID-19, to name a few. So today, experts estimate that there is a 47% chance of another pandemic as deadly as COVID-19 in our lifetime. Yet, despite this warning, we remain unprepared. So during COVID-19, governments enacted lockdowns based on unreviewed models, ignoring the 2019 WHO guidance, which explicitly warned against border closures and quarantines due to weak evidence and high harm potential. A Johns Hopkins meta-analysis later found that lockdowns reduced mortality by only 3.2% while disrupting global economies. And meanwhile, only 2% of people in low-income countries were vaccinated by mid-2021 compared to 70% in high-income nations. And according to the Fair Farmer Scorecard, most pharmaceutical companies failed to meet basic human rights standards, keeping life-saving intellectual property out of reach, despite massive public investment. So over a century of pandemics that we've encountered, I would like to pose a question to the audience. Have we ever been prepared? I'll leave my final note on a quote by Benjamin Franklin, which states, and I quote, "Failing to prepare is preparing to fail," end quote. But in public health, it's more than failure. It's lost lives, broken trust, and deepening global inequality. Thank you.
Thank you very much, Sarah, and thank you very much to all the panelists for introducing the scope of your work within this study that the report of which we're launching today. Thank you very much for that. And we're going to move next. Jake and I are going to move next to the Q&A session. We're going to be posing a number of questions to you. Again, we invite those who are joining us as well. If you have any questions, to please also include your questions in the chat. And so we're going to be asking a number of questions of you, again, to facilitate the discussion of the panel. And Jake, please.
Yep. Thank you very much. So we'll start with Professor Ngwaba. When you were giving your opening remarks, which was actually very profound, you talked about 3 pillars that this study proposes. And the first was about regional health governance approach holds greater promise than the existing global health approach, which seems to have a lot of gaps here and there. You also talked about a regional health governance approach to complement WHO's role in global health by alleviating some of the shortcomings that you identified. And then the third one, which I think is also quite striking, is regionalizing global health governance, which you said can be taken towards decolonizing global health by praxis. And I think it's important to ask you this first question, which is how? How can regional health governance frameworks be restructured to prioritize local knowledge systems and health practices? And what mechanisms are needed to shift power away from historically dominant health institutions to more regional, more community-led governance?
Thank you very much. That's a very good question. I think there are a number of assumptions which need to be sort of addressed as a way to understand the underlying rationale, because I see your question as really pointing to the rationale for the work we are doing. Firstly, our understanding of global health. I teach my global health law and policy class, and one of the first things I told them is that global health, as it's currently sort of organized and oriented, is deeply colonial. And the reason why I give them that opener is to turn their minds to understand the basic DNA of the global health governance architecture as we currently know it. A system that has been designed to achieve a particular objective cannot achieve a different objective from what it was designed to achieve. Global health started as tropical medicine. Tropical medicine is euphemism for protecting colonizers from the diseases of the tropics and protecting the civil service of the colonizers from the diseases of the tropics. It will interest you to note that at the time that tropical medicine was being developed, consolidated in the global South or at the then colonized territories, in Europe and Americas, you had a different paradigm emerging, and that is the sanitary conferences of Europe, which were the precursors to what was eventually the WHO. The sanitary conferences were developed or responded to the cross-border transmission of diseases and how to stem the cross-border transmission of diseases to enable global trade. And so you see that from the very outset, global health governance architectures or apparatus, as we have them today, were not designed for particular publics. They were designed to function for particular publics and to be blind to the needs and the priorities of other publics. And so you may begin to wonder why this assumption holds true. Well, you look at the manifestations, from their fruits, you know them. For instance, when the Ebola pandemic happened, for a very long time, a lot of lives were being lost in West Africa, but there was no response to the crisis, to the epidemic. But the moment the first case got into Europe, suddenly the entire world became awake. Oh, this is a crisis that needs to be addressed. How many diseases are ravaging on the African continent, but yet are considered forgotten tropical diseases? Why are they forgotten? Diseases cannot be forgotten. They are just ignored. And so the points I'm trying to put across is the fact that global health, as we understand it, doesn't really serve everybody. The structures and the powers in global health respond more actively or more enthusiastically to certain publics than to others. And so, to your question, how do we make a shift? Well, it's very simple. The only way you can decolonize is to empower the people, the previously colonized, all right? The capability theory, Amartya Sen's capability theory, is one of such theories which I always love to use in my work to demonstrate that the goal of human rights, the right to health and every normativity around advancing health norms should be about deepening and strengthening capability to function of the affected individuals or the affected publics. And so if we want to decolonize, we must be prepared to shift the structures of decision-making, the structures of power to the periphery, where previously colonized people are ignored or are unable to be in the room where important decisions are being taken. As to the mechanics of these things, of how this will be achieved, that is exactly what our study seeks to unravel. Within the Inter-American system, which we started focusing on, but we are currently in the process of expanding this study to the African human rights system. But within the Inter-American human rights system, there are already existing structures. The Inter-American Commission, for example, works with states on a government-to-government basis. We are suggesting that there is opportunity to repurpose existing mechanisms within regional institutional contexts to be able to do the work of mobilizing states that are already doing the business of collaborating together to address shared health threats. And so the mechanisms for these projects would obviously try to engage, we sit down and engage with those little details to see whether there is indeed a possibility or if new structures need to be developed. Let me stop there.
Thank you very much, Dr. Ngwaba, for that insightful approach to telling us a bit about what the content of the study and also the work that you did within this report. I'd like to pose a question next to Dr. Amri. Okay, thank you. So, Dr. Amri, Michelle, you mentioned benefits of a regional approach, especially increased decision-making powers to relevant actors. And so my question to you is there a place for regional civil society and other non-state actors in healthcare governance? And if so, how can they be meaningfully engaged?
The short answer is yes, absolutely. Actually, I can't really imagine a regional health governance approach without including being successful without including these key players. Health is a shared responsibility that shouldn't just fall on governments. I think too often we see that ministries of health and departments of health are tasked with just addressing health. But we can really clearly see that other state actors like environment, education, finance, and more are also really influence health outcomes. So for me, this particularly illuminates the need for engagement of not just health, civil society, and non-state actors, but really actors working beyond health as well. So individuals engaged in civil society organizations are really motivated to serve the needs of the public, but by definition, they're situated outside of government. So this can really serve as an advantage for raising key issues that may not be as easily observable to those working within governments. And similarly, individuals working within the private sector can also play a key role. In many mixed health systems, the private sector plays a huge role in delivering health services. So having a regional health governance approach without this major player, to me, is a little bit illogical. I think the most obvious way to engage non-state actors would be through stakeholder consultations and engagement. This is a major aspect that feeds into policymaking. So regularly seeking stakeholders' feedback, advice, opinions, and so forth is important, and not just for ensuring, enhanced design, but also for really ensuring the buy-in of these non-state actors. I think there's also often a tendency to arrange a working group or steering group or technical advisory group of some sort. So such a group could also include individuals from beyond government, so these non-state actors. But I think ultimately, whatever design is sought, I just really want to ensure that I want to stress that including and engaging these non-state actors is of paramount importance. Thank you.
Thank you very much, Professor Michelle. I like that you talk a bit about inclusive design and what that looks like. I think even from a technological perspective, inclusive design has a lot of value here, especially when you talk about what is really stakeholder consultation, like what is a working group, what is a technical working group, and how do we rethink that to design it to be more inclusive of other types of praxis. But let me go to Sarah, which is also relevant to something you said in your opening statement as to have we even ever had a system that has worked for us in the past? And so are we starting afresh, or are we taking what has worked and deploying it in a different manner? And I want you to maybe give us a little more context about how effective have regional health governance mechanisms been in coordinating cross-border responses to pandemics? Are there any lessons that we can learn from like the COVID-19 pandemic that can inform a design reform, or like what are some regional early warning and response systems that we can sort of learn from the past? I know you mentioned other pandemics. There was the swine flu, there's Ebola, monkeypox, but is there any lessons we can learn from this, from our experience so far?
Yeah, certainly. So during COVID-19, regional systems showed both strengths and weaknesses. So for instance, in Africa, the African CDC was successfully able to coordinate health data sharing, worker training, resource distribution across countries. In contrast, many countries in the Americas acted individually, which was problematic, slowing down the regional response and weakening impacts. So one major lesson from COVID is that delays in sharing information and refusing to act together makes outbreaks worse. So in early stages, many governments withheld data from infections and new variants, leading to their neighbors unprepared. So meanwhile, wealthier nations secured vaccines and supplies, leaving their poorer nations to scramble, increasing a regional risk. So to move forward, we must build a stronger early warning system, enforce timely data sharing, and ensure fair access to medical resources. So regional unity isn't optional because viruses cross borders whether countries cooperate or not. So Africa's response, we can also learn from Africa's response to Ebola as a case study. Africa's response to Ebola gives us a proven model that countries work together under trusted leadership from the African CDC, which had both authority and resources. They were able to deploy mobile response teams, engage in local communities to build trust, and set up real-time cross-border surveillance. The Americans can and should learn from this by empowering PAHO and investing in joint response teams and making community trust central to public health strategy. So because the next pandemic will demand faster and more united regional action.
Thank you very much, Sarah, and also for drawing our attention to the practice during COVID that involved wealthier nations and the over-purchasing, right? The oversubscription for the vaccines and the rest of them, something that led to what was described as a vaccine nationalism, vaccine hoarding, and the rest of it, and to the detriment of poorer countries and to the detriment of countries in the global south. And that is something that we seem to have forgotten, but that also helps us, or helps me at least, in terms of asking the next panelist, Dr. Wami, the question that I have for him, which draws from the answers that you have given. Again, the issue of vaccine nationalism, the issue of vaccine hoarding, that was even described as vaccine apartheid, right? And we saw the issue of intellectual property and trade play out rather ignominiously under the WTO, the World Trade Organization. We also saw the fact that leadership that was shown by countries in the global south, for example, South Africa, and we saw India with support from the African Union as well in sponsoring, in proposing before the World Trade Organization for a proposal that was going to involve a waiver of intellectual property rights under the TRIPS agreement, albeit rather temporarily for vaccines. And so we saw how this played out. And with that, I want to ask Dr. Wami, how then can regional health frameworks address these issues of trade and intellectual property, which we have seen to be critical components of effective pandemic response and management, especially in view of the definitions of, or the new definition of relevant health products under the recent changes that have been made to the international health regulations to include medicines, vaccines, and diagnostics. So I would like your perspective on this, please, Dr. Wami. Thank you.
Thank you very much, Professor Udoka, for the question. I think it's a very insightful one, and it calls us to engage with the realpolitik of pandemic preparedness and scratch beyond the surface of what it actually means when we talk about pandemic preparedness as not just a normative framework, but including and requiring tangible action, the word praxis that has been used quite often. And one critical aspect of praxis that needs to be unpacked is around intellectual property and trade, like you rightly mentioned. And as we will see with the pandemic treaty that seems to finally have been agreed upon, one of the most problematic issues was regarding the question of technology transfer. And so that speaks to how important it is that we address the intellectual property dimensions of pandemic preparedness. So I think one of the key interventions a regional framework would have to do is to build on the global systems that we already have as negotiated in the IHR, like you rightly mentioned, that has expanded on what we mean by health products. And probably be more specific. Regional instruments will probably need to be more specific and also consider the trade implications for the region. So for example, in Africa, there would need to be some form of coordination between the AFCTA that is taking up steam on the African continent and ensuring that the regional instrument builds on that existing framework that we have, but also ensures that there is no sacrifice of trade for intellectual property. So it's almost like a balancing act where you're trying to balance the need to ensure that the region builds its economic capacity, but at the same time, focuses on the health needs of the people. Because as we've seen with the global health governance framework, the focus has been on the protection of vested interests. So regional systems would have to ensure that they are people-centered in such a way that there is a balancing of intellectual property law with the needs of the region. For example, some of the work that I've been doing on the mRNA hub in South Africa has shown that there is need for an enabling intellectual property environment for you to be able to build vaccine manufacturing capacity. So while there may be political will, while there may be support from even the WHO, without local law that creates an enabling environment by having an examining status for patents, for example, allowing vaccine TRIPS waivers, for example, what will happen is that you may have the capacity, but if you don't have the legal enabling environment, then there won't be a sufficient action. So I think the major focus of a regional intervention would have to be focusing on the needs, the intellectual property ramifications for that region, and balancing the desire for more trade with being people-centered. So I think that would be one of the ways that regional instruments can build on the global health governance frameworks as we currently have them.
Oh, thank you very much, Dr. Wami. And I want to ask other panelists a question of what you said. You talked about the issue of the real politic, that there might be political will, but then there might not be sufficient IP law that addresses the need for vaccine sharing, which Sarah also talked about when we're talking about, sorry, even Dr. Doka talked about this vaccine nationalism, how people are not able to share life-saving resources because of IP protection. But I still see all of this as genuinely political, like still part of this real politic around health governance. And I want to ask Professor Michelle, now that we're talking about regional equity in terms of a regional health governance approach, how can regional equity be safeguarded within this, regional health framework that can avoid reinforcing the existing geopolitical disparities that we already see in health governance?
Yeah, it's a great question. Because my work really largely focuses in on health equity, I think I could think of different ways in which how we can approach equity and really how it can be safeguarded. So for instance, I think if we think about health equity in terms of how regional health governance can or would affect health outcomes across individuals and groups, with this specific understanding, equity would have to really be central to a regional coordinating body of some kind that has to be immensely well-versed in understanding what equity means, really recognizing that equity can be approached in various different ways, and ultimately to ensure that equity guides and really drives policymaking broadly. So in this specific approach to equity, in other words, we really want to ensure that consideration of inequity is afforded across the region and to various groups, in addition to individuals with varying identities and intersections of these identities. Another way that I think we can think about equity and how it can be safeguarded in this regional approach is really through process. Because global health practice largely entails that resources, ideas, power flow from the global north to the global south, recentering decision-making power at this regional level really allows us to afford improved equity, both in this, particularly in this process, right? So that helps, I think, with to avoid reinforcing, existing geopolitical disparities. So I think to sum up, really taking this regional health governance approach affords governments and various stakeholders greater autonomy to direct policy and allocate resources where they're most needed, fostering a more locally driven, context-specific outcomes, interventions, policy design, and so forth, and really emphasizing equity throughout this process as well.
Let me quickly jump on that question, because that question has just touched on something that is really of interest to the study. It's quite interesting to note that we recently secured a knowledge synthesis grant from SHORK to undertake a bit of work that is centered around this idea of equity. And that would allow us to really sort of come up with a very firm ideation of the way we understand equity and what equity can contribute to the project. And so, for example, our grant is framed by three questions, but two of which are very relevant to this discussion about equity. The first question is really about asking whether there are examples that can inform the design of a regional health governance approach for equitable pandemic management in the inter-American system. And the second question is what such examples, if they exist, tell us about how equity is understood and deployed in the regional health governance context. And so we're going to be conducting a scoping review and meta-analysis this year that would allow us to sit with the literature around equity in the regional context, and equity generally in health systems governance regimes. We want to understand what that means, how it has been traditionally deployed, whether or not there are gaps in the deployment of equity, and how those gaps can be closed. And so there's quite a lot of opportunity for expanding on this concept of equity, because that is really central to all of the work around, reform and repair, even in the context of the international health regulations that were revised in 2024, and even in the context of the current pandemic treaty, equity has been very central to both of these projects. And that tells you how really important the idea of equity is to the work we are doing.
That's amazing. And congratulations on securing the knowledge synthesis grant. I think that's another, that will produce another source of research and document on this area, because there's not really much literature. I'm finding there's really not much literature on how these frameworks could actually apply to other regional systems as well. So, but I think this is a great starting point, and hopefully that would synthesize to other regional systems as well. Thank you.
Thank you very much for that. I have a question for Sarah. Yes. So, Sarah, earlier you spoke about the role of a human rights-based approach to pandemic management and how we need better preparation to combat public health emergencies and pandemics. So, the question that I want to ask you is, how then can regional health bodies enhance equitable access to health technologies and resources, right, across member states? Again, seeing how important technology is to ensure that we're better prepared for pandemic management.
So we can do that through PAHO. This is like a system that's already there. So PAHO is a Pan-American health organization and the main public health agency in the Americas. So during COVID, it helped countries improve their healthcare, buy vaccines, help train workers. So by focusing on PAHO, and it can help countries work together to improve health, respond to emergencies, and assess vaccines and medicines. So to make access more fair, PAHO helps countries buy the vaccines in bulk through a revolving fund, making them cheaper and easier to get access to. It also supports local vaccine productions like in Brazil and Argentina. So countries aren't fully dependent on outside suppliers. So they were helping countries produce vaccines in-house, cutting down on buying vaccines that were overly priced coming from countries that could afford to make these vaccines. So PAHO also trains healthcare workers, sends medical equipment, and helps management of outbreaks across borders. But to keep doing this, it needs steady funding. And that was majority of the issues that during COVID, a lot of the member states who are poor were not able to produce funding to be able to support the system as a whole. So funding is an issue, and the power to coordinate across regions, because what PAHO can give is advice. And in a lot of instances, they can only tell you what to do, what the recommendations are. They cannot enforce it, and states are not very happy about giving away power. So that was one of the issues. So when countries work together through PAHO, access becomes more about need and not about income.
That's a very good point. Access become more about need, not about income. And I think this is it's a critical insight that I think the report covers. When I was reading it again this morning, I think there was a point where, yeah, Sarah, you were talking about, the objective for integration into the architecture of global health governance in terms of this need versus access, financial competency versus expertise. And I want to move this to Wami's point, which is centered around like law and intellectual property, because you did mention the pandemic treaty. And I know that the treaty has not yet been finalized. There was hope last year at the 77th World Health Assembly, and negotiations were stalled, right? I think some countries are realizing, okay, there's a lot of money that will be involved into this treaty, or maybe not. Again, I don't know much. You are the expert here. You come to this place with both health and law expertise. And so my question to you is, how might a binding pandemic treaty, how do you think a pandemic treaty that is binding, how will it alter the authority and the autonomy of regional health bodies in emergency health decision making?
Thank you very much for the question. I think the word binding is a two-edged sword here. So on one hand, we can think of binding as being an enabler where we ensure that previously fragmented approaches are no longer possible. And what we now have is the ability to have a truly international and equity-based approach. We can think of binding in that sense. The converse is we think of binding as, well, regions want to take up a different approach to pandemic response, but they are now bound by the pandemic treaty. I think with regards to the second understanding of binding, that may not necessarily be the case, because currently, as we have it, the pandemic treaty has been negotiated by all state parties in the World Health Assembly. So the assumption is that whatever ends up in the final document is a product of long and protracted negotiation. And even though the content that we may want may not all be reflected in the eventual document, at least there is a common denominator that everybody agrees on that ends up in the final document. So for me, binding will then be, our understanding of binding will then be that there is a common denominator that has been set by the pandemic treaty and the IHR, but there may be need for building on that. So in that sense, binding wouldn't be so much about constraining activity. It would be about creating a basic minimum that all state parties need to do to help build a global health governance response. And if anything at all, what would be required is for regional systems to build on that and to focus on aspects that are peculiar to their own health needs. So a good way to conceive of it is to think of the covenants, the international covenants as we currently have them on civil and political rights and economic and social rights, and then the African Charter. And so the African Charter builds on the international covenants and creates an approach to human rights that is specific to the African understanding of human rights. So in my own conception of a regional approach, an African intervention, for example, could focus on more collectivist approaches that builds on the pandemic treaty. So it is not so much as one either or, it is more about building on the existing established minimum, because one of the main critiques of the pandemic treaty is that it is not specific enough. And part of the reasons why it is not specific enough is that regional blocks, negotiating blocks, cannot all agree on the specifics. And so what has been agreed on is the basic minimum. So I guess the real question would be, how can regional frameworks build on the existing agreed minimum core, for lack of a better term, a minimum core as set by the pandemic treaty, and then specifics, maybe Africa would want to focus more on technology transfer, building vaccine manufacturing capability. PAHO may want to focus on trans-border issues, maybe around America and Mexico and Canada, especially in line with the current political contestations that are going on. And so each region would want to create a system that focuses on its own specific need and builds on the existing international framework that has been set by the pandemic treaty. So I think that would be one way to go about it.
Thank you very much for that, Dr. Wami. I have two questions for Dr. Ngwaba. I think that I'm going to ask the two questions to Dr. Ngwaba because I think that they follow from each other. Now, reading the report and also listening to you, Dr. Ngwaba, it is your skepticism about a global approach is apparent, and your hopefulness about a regional health governance approach is very apparent. And in fact, you state that a regional health governance approach holds greater promise for equitable pandemic management. Again, the emphasis on equity. And you also mentioned the importance of international solidarity in ensuring a right to health for citizens of the global south. Again, something that you mention and you talk about, that the way forward is in terms of praxis that decolonizes global health, that decolonizes health governance. And so the first question that I have for you is, given normative developments, or in fact the lack thereof of these normative developments on the right to international solidarity, to what extent do you see this concept of international solidarity as driving health governance, following from the research and the study that you have undertaken? And then the second question that I have for you is, again, given that the study was focused on the inter-American system, is there any scope within future work of the study to comparatively look at other regional health governance frameworks, especially in the global south? So, for example, the African Union mention has been made here of, I think Dr. Wami said he looked at the African Union. Sarah talked about the Africa CDC, and we saw also how important the African Union, and the work of the Africa CDC was in terms of driving a discourse in this regard. So is there any scope within the future work of this study to comparatively look at other regional health governance frameworks in the global south? So, for example, the African Union, to inform policy and processual developments to ensure the right to health for citizens of the global south.
Thank you very much, Dr. Udoka. This is such an important question, and I'm going to take a bit of time to sort of unpack them. First, I think your assessment of my state of mind is very accurate and precise. You do indeed quite eloquently sum it as skepticism of the global order and a global regime, and hopefulness for a regional regime. And there are good reasons for that. In terms of my skepticism of the global order, let me explain a bit of that, why I come from that place of skepticism. It's because I have studied a number of responses at a global level to crisis in the past, and especially health crisis. I see that there's always a quickness to put together an agreement after every crisis, every health crisis, either a declaration or a resolution or a treaty. But then when push comes to shove and a crisis manifests, there is a complete abandonment of those agreements. We saw that during the COVID-19 pandemic. When states were acting in apartheid or hoarding vaccines in nationalism, it wasn't as if there were no international instruments that said that states shouldn't do that. There were indeed international instruments that obligated states to, act in solidarity. But it suddenly became very convenient to ignore those international instruments. And, states have very, very, believable reasons why they choose not to, follow those regimes. And so it leads me to believe that, when the moment of crisis passes, then we revert to status quo. And that makes me have very little faith in the ability of our global the global governance architecture in health to be trusted when it really matters. And to the reason for my hopefulness, it's a really very pragmatic reason. And I sum it this way: it's easier to do solidarity with your neighbor than to do solidarity with someone who is not your neighbor. For example, people are already in the habit of doing solidarity with their neighbors. The reason why Canadians are currently up in arms against the United States and the tariff regime is because they feel betrayed that their closest neighbor, who they've always done solidarity with on a government-to-government and people-to-people basis, should react this way. And that is why they are completely disappointed and up in arms with the raised elbow movement and all of that. And so what does that tell you? It tells you that solidarity is something that is really best practiced, at points of proximity. And so building on that logic, My thinking is that if states that are already at the regional level doing solidarity work on a government-to-government and people-to-people basis should deploy that solidarity to an area of shared interest and shared risk, that is health during periods of pandemic, it is easy for them to say, you know what, we need to come together, pull resources together, act as a collective to address this. Much so than it will be for you to ask, for example, Canada to pay attention to what is happening in Guinea-Bissau. Why should Canada care about Guinea-Bissau? Guinea-Bissau is in the forgotten part of the world as far as Canadian policymakers are concerned. And this might seem a bit harsh, but that is the truth. When it is a period of crisis, states will retreat to their core base and say, you know what, we need to act to protect our immediate interests. And that can be extended a bit to the regional interest because states can selfishly identify a risk to them if they don't pay attention to that. So that's a pragmatic reason why I think that there's a reason for hopefulness if we strengthen the regional basis. And at the same token, by the same token, if the African system is also strengthening its regional context, then it doesn't care that the Americans are not paying attention to what is happening on the African continent. And that leads me to the second question you asked about whether there is space for this project to sort of develop towards, the African region. Absolutely. Matter of fact, a couple of weeks ago, the steering committee of the project met and we took an executive decision to begin to expand the study towards integrating the African human rights system or the African as a regime into the study so that we can have a basis for like a comparative understanding of regional systems. Of course, we do not approach this study with an assumption that every regional system is a monolith or all regional systems are the same. Each regional system presents its own challenge. For example, in the Americas, one of the challenges we have to grapple with is the fact that Canada is both a site of coloniality and also a colonial power. At the same time, Canada is a site of oppression for other groups of peoples. And so how do you address this, this dialectics, this Janus-faced system or reality? That is something that we need to sort of sit down with. On the other hand, the African continent is a site of oppression. Generational oppressions from slave trade to colonialism to neocolonialism, ongoing oppression. It's also a site of dispossession. How do you then frame a regional approach that requires a shoring up of capabilities and power structures to be able to address, to be able to have the capacity to address health threats such as epidemics and pandemics? That requires a different kind of thinking, obviously. But then there is value in placing these two regimes side by side and thinking through what equity will mean in each of these different contexts. I suspect that our findings will show that equity in the context of the Americas would work and operate differently to how it would occur or to the kind of demands it will make on the in the African context, where we are dealing with instances of multidimensional poverty, instances of very acute gaps in the area of attention to social determinants of health, where there is near absence of infrastructure, existing infrastructure for example, research and development, which is very critical to the pharmaceutical industrial complex that supports a lot of the advancements in health. And so this is all to say that, yes, there's reason to be hopeful about the regional context because the global context is not exactly demonstrating any reason for enduring faith. And secondly, the work is obviously expanding to the African regional context because there is much value to be learned from what an equitable pandemic management system within that regional context would look like. Thank you.
Thank you very much. I know we are already out of time. I'm going to pick up a conversation with Professor Uche, maybe over coffee, as to the future of when it now becomes the same form of competition between regional systems, and maybe how some states might push towards desolidarity if they don't find that they have more leverage within a regional system. But conversation for another day. Do we have time for any questions? And I'm just checking to see if there are any questions from anyone in any of our participants. If you have any questions directed to the panel generally or directed to individual panelists, please feel free to use the Q&A box. We have just about 15 more minutes, if any. I wanted Sarah to quickly, I don't know if you have a minute, to talk a bit about, USAID cuts, a lot of mass layoffs in health agencies. There's a lot of politicization when it comes to public health. So in terms of the future, if we get to this future where regional systems are more strengthened, and like Uche said, you can only be, the neighbor principles, you're more neighborly, you have more solidarity with those who are around you. Do you think we are prepared for the next pandemic? Because you mentioned some statistics about a projection that we might be experiencing another one. And what steps are to be taken to ensure that we are, if you have any answer to that, Sarah?
With the US cuts and health agency layoffs, the rising politicization, like I don't think we're ready. We are not ready, I guess, for another pandemic, for the next pandemic, because the freeze on the US foreign aid dismantled key programs across Latin America and the Caribbean, including programs that tracks outbreaks, that supported maternal health and coordinated emergency responses. So these losses directly impact PAHO, which depends on that to support the people in the region, to support regional efforts. So at the same time, US public health agencies have also downsized, weakening their ability to back PAHO or lead collaborations. So PAHO is now expected to do more with less. So less funding, less coordination, less trust. So yes, WHO just finalized the draft pandemic draft treaty promising equity and global cooperation, but treaties mean little without regional capacity. So the Americans can't wait for help. They need to build it. So this means restoring health funding, empowering PAHO, and involving local leaders in pandemic planning, because next time I don't think we would have a second chance. Yeah. Thank you.
Thank you very much. Okay, we do have some questions from our participants. Professor Udoka, do you want me to read it? Okay. So I'll just read the three questions that we have, and if any panelists would want to take that. Ida is asking, it may be important to assess the risk of a regional health governance approach, but what potential risks can the panel foresee? So if there are examples of these risks that we can foresee, that would be what Ida would like to know. And then what would be some potential risk mitigation strategies? And then we have Regina, who's saying, thanks. They're not familiar with any of the health governance systems at all, so excuse their ignorance. But they want to know, how would an ideal regional health governance system incorporate mental health care? How would it address related shortcomings arising from a WHO model? So maybe we can start with a question around risk. What are the potential risks that the panel can foresee, and what would be some potential risk mitigation strategies?
Maybe let me just jump on that question very quickly. Potentially, I think there is consensus in the panel that a lot of the conversations we're having in the panel is one that has implications for the real politics of the states. Unfortunately, there are lots of dimensions to that. It goes, and it differs on a region-to-region basis. For example, if we speak about the Inter-American system, where this work is currently focused on, what you observe is that there's a real risk of uptake. Okay, it is not as if there haven't been previous initiatives in the past at regionalizing, at least in the context of addressing specific priorities. In the Caribbean, you've had such initiatives. For example, the Caribbean have CARIFA, which is the Caribbean Public Health Agency, which is a sub-regional entity. You have, in the Central American states, you've had such initiatives. In the South American states, you've also had initiatives. Now, what is quite revealing about these initiatives of the past is that they have been bedeviled or hamstrung by a number of shortcomings either in the institutional design, where states are unwilling to sort of commit to the invasive nature of collaborations, or a situation where they are specifically designed to achieve very limited objectives. And so there is that danger, okay, that in envisioning a regional health governance approach, that we still have to confront the real politics of statehoods and state sovereignties, and of course the differing aspirations or desires of states. The other thing is that in this territory where we are currently situated, Canada and the United States in particular, they always have this habit of distancing themselves from the Americas. They like to think of themselves as exceptional. And even in the way that the governance apparatus in the Americas, for example, the Inter-American Commission, treats these countries, one major critique I've heard and I've read about is how the Commission sort of treats Canada and the United States with a kid glove, while it takes out, the hammer on the other states in the Americas. And so in that sense, you see that there is an inequality, of demands and responses, where these two great and medium powers can get away with crime, and then the others are held accountable. There's a different sort of double standard to it. And so that's a danger that we can face, we can expect to face. And look, the potential mitigation strategies have to involve, a design structure where the individuals, the states who understand that this is really about us, this is about our ability to survive against odds, will be prepared to put away these considerations and really put down something, a real structure in place that can address threats when they happen. As COVID-19 demonstrated, when it happens, no amount of border you put in place or no amount of lockdown can save you from the impact. And so if you understand the invasive nature of the harm that can happen, then obviously you should be prepared to take equally invasive measures.
And I would like to add that a potential problem that I foresee is because when you're looking at the inter-American systems, they have different health systems. So that could also pose a challenge, because not everybody, some people have privatized systems, and some people have systems that are, everybody can seek healthcare. So that's a challenge that I foresee moving forward.
Another challenge I foresee, at least in the context of Africa, is the real challenge of economic means, because ultimately it boils down to the dollars and the cents. And so while you may have really good regional instruments, they require material capacity to implement. And a lot of African states don't have enough resources. And so a real challenge may be that the responsibility of running those regional systems may lie on one or two countries that, while they may be better off, are not that economically buoyant themselves. So the responsibility may lie on the usual suspects: South Africa, Kenya, Nigeria, and with other states not being able to pay their dues or lift their own weight. So that is a potential risk. But I think on the flip side, what must happen is that there must be a concerted focus to build capacity, economic capacity, because ultimately economic capacity leads to manufacturing capability. Manufacturing capability helps provide the funds to strengthen health systems and create interventions that allow for greater independence. And ultimately, I also think this also links largely to the problems we've discussed around the erasure of aid and the implications of that. In the wake of the USAID retreating, there is need for regions and states to build their own resilience. And so now there's no better time than now for regions and states to kind of just suck it up and do what is required to build local capacity. So I think while there may be teething problems, the hard work of building the material means must be done now before the next pandemic.
Yeah, and I would just add to that, I couldn't agree more. I think capacity building, resources, these are major aspects that need to be considered. But I also think in terms of the governance side of things, one potential challenge is this optics or perceived or actual redundancy. If we look to the WHO model, where there's these 3 levels of the organization, from headquarters, regional offices to country offices, one of the major critiques that emerges is around the role of these regional offices. Country offices are on the ground doing applied work, whereas the headquarters level is providing global governance. So what is this role of the regional level? And I think that is one, potential risk of this kind of approach. But I think a mitigating strategy is very much the strength that it affords. It affords this cross-regional perspective and look at more of a bird's eye level without going too global and, missing certain aspects, certain topics, certain populations, certain areas, and so on and so forth. So I think that is a mitigating strategy in and of itself, and having really open lines of communication is pertinent.
That's a very important point you made, Michelle, about this cross-regional engagement and the bird's eye approach, because it relates to what Darling is asking about. That, they share skepticism around the global health governance, but they doubt a regional approach would actually suffice, and they say, Africans, for example, are quick to say African solutions to African problems. I think we see the same in the inter-American system, where the dichotomy in terms of culture between the Caribbeans, even across within the islands themselves, but also compared to like a Canada or like a Mexico, for example. So, implementation also is another thing, how feasible is this regional approach in comparative to a global one? And in terms of implementation, is it going to be effective? Would this produce an effective regional health governance system, or is it going to be duplicitous of what we're seeing around the global one? I don't know if we have time, but we see some more questions are popping up. Professor Udoka, what do you?
I think we can take there's a last question there that is on given how diverse the Americas, right? There's a question there. There's perhaps there's also another question in the chat. Maybe perhaps uh, uh, Professor Ngwaba can respond to one of the questions on the chat from a student who's asking how they can participate or they can develop a career in this area. So I think the question in the chat can be addressed by Professor Ngwaba while we take the last question on the Q&A.
So I can actually merge sorry, go ahead.
To very quickly take the last question, I will encourage the students, since the students are 1L incoming student, please send me an email and we'll set up a conversation around how that can happen.
Okay. And so we can merge the other 2 questions in the chat. I think Alexis is saying, how can we empower regional health networks, especially in times like right now, when the major powers, especially the financial powers like the US, are not only pulling funding from health organizations, but somehow there is implication around spreading misinformation, which degrades health confidence. And so Alexis' question is synonymous to the one asked by an anonymous attendee, is the diversity of how the Americas is and how public health professionals how can they ensure regional health framework that it does not to approach future pandemics without having this savior complex. So it's dominant states within a regional system that have massive effect in terms of funding, in terms of misinformation, but also how do you balance it where there's that imperialist dimension towards that? So
Let me take the last question. I think I can say that in a few seconds.
Okay.
The response to that question is
maybe you can do this while making your closing statements as well. So we all go around and say something.
Yes. The response to that is decolonization. This project presents as a decolonization project, and that means that essentially both the design and the agenda, the driving of the agenda, is done with sensitivity to specific contexts. And so I believe that if we pay attention to how power essentially is deployed and has traditionally been deployed in global health, and we seek to correct that in the way we go about both our research design and in operationalizing some of the ideas that come out of the research, I believe that we'll be able to stem some of those, mollify some of those anxieties. And, again, in wrapping up, just to say that it is a very energizing to feel the enthusiasm in the room about this conversation on deepening equity in the context of health pandemic, in the context of regional systems. And I really welcome further opportunities to continue to engage, and I would encourage participants to continue to follow the work that the Regional Health Governance Study will be putting out in the future. Thank you.
Okay, any last words from any of the panelists? We are right on time. And just to let the participants know that we appreciate your engagement, you're going to get a link to a post-launch survey. We encourage you to please take that survey. It's going to be instrumental towards driving the work that we're doing moving on. And of course, some of you have already seen the full report, or you might be itching to read the report. I read it. It's a masterpiece. It's a manifesto. It's literally everything in one, not just a report. Very instructive. So you can look at the website right there on the screen to access the full report. And yes, any last
by way
word?
of by way of closing remarks, I think one intervention that we can also consider strongly is South-South collaboration, and not just simply thinking in geographical terms. So while you may have countries that are geographical neighbors, they may not be ideological neighbors. And so the practice of neighborliness may include reaching across the aisle, the geographical aisle, to countries that are at the same level of development, same level of economic means, and have the same outlook for what the future should look like for them. And so structures like BRICS, for example, give us an idea of what such collaboration would look like. Whereas you have Brazil, India, and South Africa being on different continents, but having the same economic and ideological lens of what the future should look like. And so I think in addition to, so it wouldn't be a case of either or, but in addition to regional models, there's probably need to explore South-South collaboration, so that while each country may not have the means of an America, for example, together, they may have more resources, and under those circumstances, they can deal with each other as peers, and not less of a top-down approach, but as ideological peers looking to chart a course forward for their approach to regional and pandemic treaty preparedness. So I think that would be my final intervention on one of the possible ways this project can move forward. And I look forward to working with everyone at the next stage of the project. And thank you very much, Professor Ongwaba, for the opportunity.
Thank you very much. Sarah, any final thoughts?
I think based on everything that I have found in the research and based on what everybody is talking about, it's important that we communicate with each other, because just a simple conversation can go a long way. Like, we need to reassess measures. If measures are not working, why are we still implementing them? And that's what we found during COVID. We have to listen to experts, like what worked, like which countries did better. How can we learn from them? So it's like gleaning from areas that works. Yes, geographically they're different, but there are a lot of things that we can also adapt from people that did better. And also include the general public in decision making, because we don't know what the next pandemic is going to look like. And the previous pandemic showed that people felt excluded. The general public felt excluded because they didn't know what was happening. And the pandemic affects everyone else. It's going to affect all of us. So we also want to be a part of that conversation. And just starting conversations like these helps a long way in our preparation for what is to come, even though we don't know what it's going to look like. But we should know that there is something coming, and not think that, the pandemic is behind us. But there's definitely, we should be in expectation, not to scare anyone, but yeah.
Thank you very much for that. Dr. Amri?
Thank you. I think I just want to say thank you to the hosts. It's a really fantastic report, and it comes at a really opportune time. I think it's we see that global health and the broader global health architecture is really in flux with respect to funding cuts, amongst other things that were mentioned in the questions as well. So I think it's really the opportune time to build on the momentum from this report, from these initial meetings, some of the plans, the marvelous plans, and really this great group of individuals with various disciplinary backgrounds. So I look forward to staying engaged in this work and what the future holds as well. Thank you.
Thank you very much. I want to thank the fantastic panelists that we've had today. I thank you for your insightful interventions and the work that you did in this report. Thank you very much. I also want to thank my spectacular co-moderator, Jake Efodu, for the great work in anchoring this launch of the report. And I also want to especially thank my co-chairs, Ms. Darlene Seda and Dr. Uche Ngwaba were co-chairs of the International Humanitarian Law and Human Rights Interest Group of the African Society of International Law, who are co-hosting this event with the International Law and Global Justice Initiative. Thank you very much for joining us, taking your time and being with us. Just the final plug of to tell you what we're doing. I know you can always go to our website, check our social media handles, African Society of International Law, to join whether the society or to join any of the interest groups. But very importantly, the African Society of International Law is going to be hosting its annual conference in Maputo, Mozambique on the 17th and 18th of October this year. And the theme is Africa, International Law, Arts, Culture, and Arts and Culture. And we look forward to you joining us. Thank you very much. And over to you, Jake, to close out. Thank you.
Yep, just to add a little more thanks to Brian, helping with technical stuff, Reka, Dana, and all the people who have worked on this amazing convening. I also want to thank all the research interns, the RAs, the collaborators who have worked to make this a success. Thanks especially to all the participants who took out their time to engage in this conversation. I would like to say that let's not leave this conversation here. Let's carry it forward into policy rooms, classrooms, clinics, communities, because as you've heard, health justice is not optional. It is hugely, hugely essential. So the report is a toolkit, it's a manifesto, but it's an invitation inviting you and all of us to participate in rethinking, reshaping how we can respond to pandemics and how we can share knowledge, how we can build systems, and how we can truly serve people. Thank you very much for your time and see you around. Bye.